actually in all three of your answers that leads to why I think I categorized diagnosis and education together, which is, you just focused on Dr. Lambert, pathologists who see this a lot have a way that they look at it and understand it. But I think one of the questions that we heard a lot was from patients was, what's the priority in the medical community at large, or who should we be aiming at in terms of increasing awareness of how to recognize the disease? Is it pathologists at large in the world? Is it GYN surgeons in the world, et cetera? Is it primary care physicians? Because I think something Dr. Sardi said earlier was, you know, if patients can get to you sooner, the treatment can be more effective. That one of the biggest problems is people aren't getting the treatment until 5 years of treatment that really wasn't the right thing to do. And so how do we, what's the right part of the medical community to focus on in terms of front-end loading the education to get the right diagnosis?
Radiologists.
I think looking at the number of patients that are treated, probably the most misdiagnoses are made in women. Why? Because these patients will frequently present with pelvic masses, and the reason why it's a pelvic mass is that by gravity this mucin falls in the pelvis and appears like an appendix cancer. The other issue is that these patients that have this mucin accumulation have elevated CA-125, which is the marker that is associated with ovarian cancer, but it's also associated with appendix cancer or other cancer, to the point that all these tumors CA-99 and CA-125 can be markedly elevated in over 60% independently in appendix cancer, for example. So that leads to a confusion, and that's probably the major problem that we see, because there are incomplete cytoreduction frequently, and most important, more difficult, extensive disease in the pelvis, which is going to make the next surgery a lot more difficult.
Two things. One is to add to your who do we educate and how do we help awareness. One of the things that we've run into, which was caused a delay in my brother's surgery, was that we were going to Ox Chase Cancer Center. Almost every doctor that we talked to steered us away from the surgery. Okay, so cancer oncologists, I mean the oncologists themselves, gastrointestinal oncologists, need to be made aware the success of these surgeries. They, to this day, I mean, he gave his blessing and said, my brother had the surgery. He had the surgery in November or October, and he said, I'll give you my blessing to go, but we're not recognizing it. That's a huge problem. It's not just in the emergency room when he went in 18 years ago with what thought to be appendicitis and got sent home because there was nothing there. It's not just radiology, it's the cancer oncologists themselves. The other thing that I wanted to comment on in yours is the CA-125 levels. Isn't it true that CA-125 levels can be elevated for no apparent reason? As far as that isn't an indication of cancer itself?
Yeah, tumor markers are really not used
unless you're
as a diagnosis.
Yep.
And I have been shown over and over, sometimes patients come and say, listen, can you do a CA-125 to see if I have ovarian cancer? I haven't shown that it doesn't work. Okay, there are some other reasons in all these, another reason why these markers could be elevated. So we don't use it unless the patient has been, and they're very good for the follow-up. If you have elevated CA-125, frequently these tumor markers start going higher before you can even recognize the tumor by any other means.
Okay.